Okay. Here we go. We are live at MrPopZitLive. And I'm going to let some people show up. Let me get my pictures warmed up here. I really need to get a better presenter thing. I just have an iPad, but it works. Let's see. Here we go. People are coming in. Awesome. I know it takes some time. Laura, hello again. Shauna, hello. Thank you so much for coming over. I like MrPopZitLive. It kind of funnels things in a little bit, and the discussions can be a little bit. I can get to pretty much all the questions usually. Fairy Hedgehog K, hello. Lauren, hello. Thanks so much for coming over to my other channel. This is nice. We can flex a little bit. Gene Mixon, South Carolina, hello. There we go. Now people are showing up. Tennessee, Andrea, Alyssa, West Virginia. Very cool. Melissa, hello. Delta Adventures. Malinois. Oh, Malinois. Okay. Big dogs. Those are cool. Brisbane. Awesome. Okay. So what I'm going to talk about here, I'm going to go over some facts. A lot of people don't know. That melanoma is the most common cancer affecting young adults 25 to 29 years of age, in that late 20s. The most common cancer, and the second most common in 15 to 19-year-olds. I didn't even know the 15 to 19-year-old stat. That's the second most common type of cancer. It's pretty crazy. And all it takes is just 5 sunburns. As a teenager and as an adult, you're 80% more likely to develop melanoma in your lifetime. And that's a staggering number. You know, these are all from the Skin Cancer Foundation, all of these. And that's just, you know, how many people do you know over the age of 40 when we didn't really have great sunscreens back in the day? And there was even some people that would say, if you had acne, go get some sun. It helps with it. It'll dry it up. You know, you go to the beach, and a lot of people did that. And, you know, those couple sunburns are really, there's a huge group of people, 40 to 90 years of age right now, that are a litmus tests. They're 30 years, 40 years of sun damage now advancing, and they're showing us, wow, UV light and all of these skin cancers. And there are a ton. It's nice to know that 94% of people treated for melanoma are still alive 5 years after the diagnosis. And what that's saying is early detection is crucial. If you can catch it early, it's a very easy thing to live through. And that's the good news. And, you know, catching it early is key. And I'm going to show you, when you don't catch it early on a picture, what happens. I'm going to show you some textbook melanomas. And then I'm going to show you some rare melanomas, and I'm going to tell some stories on each one. But as I said earlier on my regular live, ultraviolet radiation proven human carcinogen, and indoor tanning devices. I'm going to tell some stories about those too. These can emit UV radiation amounts 10 to 15 times higher than the sun at its peak intensity midday. 10 to 15 times higher. And the reason is it's so focused, and a lot of times they're using UVA. UVA goes deeper into the skin, and that's what causes the damage of the melanocytes. And the melanocytes, when they're damaged, start producing melanin to try and protect you from further damage. And that's what a tan is. You're releasing melanin. You're releasing melanin trying to protect yourself. And people are like, oh, you know, I get my base tan to protect myself. I always tell people that base tan is a sign of damage already. And yeah, you know, darker skin tones do have some natural protection against the sun. They did, gosh, this was a study I read 15 years ago, but they kind of were trying to see how much protection on the Fitzpatrick skin scale, what is the difference in from Fitzpatrick 1, Irish skin like mine, Northern European, very, very light eyes, redheads, to an equator like African, in Fitzpatrick 6, very dark skin tone. They did a study to show that it would take 250 years of damage, 5 times the amount of sun damage, to get the same risk as it would in 50 years of a Fitzpatrick 1. So it's about 5 times. So when you come down the scale, 5 Fitzpatrick 4s, Latin skin, Pacific Islanders, Indian, when you're getting into those 3 4s, you're probably 2 to 3 times, 2 to 3, probably 3.5, 4. You have some natural protection with that melanin, but it does not mean that you can't get any of these cancers, and in particular, nail beds. Especially with African Americans, that's what we look out for. Darker skin tones, dark Indian skin, Pakistan, these different parts of the world where there's just more sun, they have more melanin in their skin, but their nail beds are all the same. We all have these light nail beds, and you can get acral melanoma, acral lentiginous melanoma, and it can be a killer. So, toenails as well, palms, bottoms of the feet. These are all places where a lot of times the skin is very light in most people. So that's important. And there was one study in particular that they mentioned, and I think there was like 60 something women. It was a group of women under 30 years of age that were diagnosed with melanoma, and 97% of them had a history of tanning beds. 97%. I think it was like 60 or 61 out of 63 in that study. And I have found this to be true. In my own kind of personal, I stopped counting, I think, around 700 around year 10, I believe it was, in practicing medicine. It's been a little over 1,000, I think now 1,100 that I've caught in 15 years. But when I had stopped counting around 700, there was about 350. About 50% of them were people under 45. I was about 50-50. It was pretty amazing. And out of that group of 350 people that I had caught, in like 40, 45 or younger with a melanoma, I asked every one of them, "Did you have a history of tanning beds?" And all but 2 said yes. So that would absolutely go along with the clinical data a lot of times. And, before I got into medicine, for my wedding, I did 6 tanning sessions. My wife was like, "You're pretty pale for the pictures, man." Coming from a pale lady herself, a Norwegian, that she did it too. And, I'll pay the price for that at some point, I'm sure. I did form a lot of freckles. I had always freckles, but I noticed a huge increase. So before I was really in medicine and really was knew about a lot of this data, unfortunately, I had done it. And I know that I have people that come in, or patients that own tanning salons. And, they did a study to show that like 75 to 80% increase with just 5 tanning sessions, lifetime risk of melanoma increased by 75 to 80%. And then they did a follow-up study where they called tanning salons and they asked, "Does this increase my risk of getting skin cancer, in particular melanoma?" And 75% of them in that study said no. Which, man, ouch. Maybe they didn't know about it, but maybe they were like me when I was younger and I didn't know. But it's not truthful. And they even went on to say, no, if it was so bad, why would dermatologists use UV light for psoriasis treatment or PUVA therapy? They use light. Well, it just so happens it is UV light. It's narrowband UVB a lot of times, which doesn't penetrate as much as UVA, which is the big cause. So it is a safer form of UV light. There is a slight increase still because it is UV light, but it's about as safe as it gets, and it can help with inflammatory conditions like psoriasis. So that is true, but a little disingenuous in the explanation. So that happened. So let's talk about, and a lot of those stats came from the Skin Cancer Foundation, by the way. Some people will probably ask that. I wanted to tell you. I wanted to go over the different types of melanoma, and I know this is kind of a hard way to show it. I hope this works. There we go. Try to get it in the center. That is a textbook melanoma there. When you look, you got this color variegation. You got a real light spot there. Man, I should probably use a pen. Do you have a pen over there? Is there a pen anywhere? Let me get right here. There we go. That'll be easier. So you get that dark spot in the middle. Color variation, light and dark in the same mole. Regression, when you start to get these light spots. And when atypical moles sometimes will start to kind of involute or eat up the pigment, they'll start doing these drastic changes. And that is one of the things that we look for. Obvious. This is an obvious melanoma. This is a guaranteed biopsy. Anybody in dermatology sees that, they're cutting it. And you can see the size of this. 4 centimeters across. That's a good size mole. And a lot of people would say, how do you biopsy that? And there's a lot of discussion and argument and how you would biopsy this mole. Obviously, if it's a little tiny one, we like to go deep if you can. If you have a 4 millimeter, either you're doing a deep saucerization or a punch biopsy. A lot of people, hello, Leah, good to see you. A lot of people would say, what I would do on this is I do a deep saucerization all the way across. I would shave this whole thing off with a wide blade. And the reason for that is the heterogeneity of a lesion. And what that means is these moles, when they have nests of atypia and they're changing in different areas at different speeds, they're not uniformly turning into a melanoma. So if you did a punch biopsy in one segment of that, and you get a moderate atypia or a severe, it could be a melanoma 1.5 centimeters to the right. So, and you're not getting a good sample, it could be dangerous because you will not get a good read from the pathologist. And even the pathologists, they come, when they get a big piece like this, they will take slivers out of the segment they get. It's like having a loaf of bread and taking 5 or 6 pieces out. They're not even seeing the whole thing, but they try to take it through there in a random sampling that gives us a good insight. But in one like that, if you get this whole segment across and they can take a lot of slivers, there's a way higher chance they're going to diagnose melanoma than if you did 1 or 2 punch biopsies, maybe even in the darkest spot. You want to get a good sampling. And as a clinician, that is so important. Red moles they're not really moles. They're usually hemangiomas or angiomas. They're a collection of vessels. However, there are amelanotic melanomas that can present pink or red. So you really need a professional looking at them. They can tell usually right away if it needs to be biopsied or not. But good question, silver zinc. Let me make sure. Yes, nobody's calling from my office. So that was one. Let's go to another here, another textbook. Here's a good showing, try to get it up close to the camera, of regression. Right in the middle, right there. So you see that black outline right there? That's a mole that was changing. You see, it's kind of bright when it gets up there. You see that middle where it's almost losing pigment. That's color variation, light and dark in the same mole. That active border right there of black, that's definitely a biopsy for sure. That was a melanoma. These are all melanomas that I'm showing you. So you're going to see some, they're like, what? So another textbook. I'm starting with the textbook melanomas here. So you can see right there that, the black, anything black on your skin shouldn't really be there. There are dark moles, and especially in darker skin tones, you can have very dark moles, almost black, but they usually have a round border, all one color. Those are things we're looking for. History, how long has it been there? Is it itching, bleeding, scabbing? Those are all good questions to ask. But overall, just as a kind of, words to live by, literally, if it's black, go see a professional and see if they want to sample that and they can tell you if it's benign or not. I usually take off most everything that is black. And that's just another textbook. 1.5 centimeters, good catch on the back. I do see patients, and I've talked about this so many times, in the Inland Empire where I'm at. There are some people that have never had insurance, that sometimes have been homeless for years and then got state-run like Medi-Cal, and they finally get insurance and they have advanced everything. I mean, not just skin cancers, but advanced clinical diagnoses, skin conditions that have gone way too long. And this is an example of that. This is the bottom of a foot. And you look at that, most people are like, I would have been at the doctor's when it was like, just a tiny little spot on the edge there. And you can see that light skin in the middle. You can see the browns and the black and the completely white regression. It's got everything. This is an obvious melanoma that we biopsied, and that is a amputation at the ankle. That's the treatment for that, removing the foot, and in checking the nodes up the leg, in getting PET scans. The treatment protocols, when you find something like this, are first of all removing the tissue, second of all getting scanned, third of all, sometimes when the removal, taking a sentinel lymph node, which there are some pros and cons to that, and some surgeons that recommend it and some that don't, but then seeing the oncologist with all that data. How thick was the melanoma? Was there regression? Was there ulceration? Was there involvement of the lymph nodes? What type? Did it have mutations or not? All of these things are important in giving you the actual diagnosis of what stage it is. And the stage means everything of how they're going to treat it. So those are all important things. And so here we go. Let me show you another one. This is another on the foot. It started, you see that little, this is all backwards, right there, that little dark spot. This whole thing, you can see this is just metastasizing. It's just spreading in the skin all the way around. It's hard to circle backwards. You have a big, huge nodule coming out, healing, bleeding. You've got the pigment going like all the way through the foot. Another amputation. It started with that little tiny dark spot. Come in. If they would have came in with that little tiny dark spot, one deep scoop, maybe a big removal, keep the foot, get a skin graft possibly. But at this point, dangerous. So these patients go on a lot of times to see an oncologist, and sometimes they come back, sometimes they don't. So I don't have follow-ups on all of them. But this is a very bad, dangerous melanoma that you'd never want to see on your skin. So when you get the little spots, make sure to get them checked. And I hope, what I want for these pictures and people watching this video is to say, oh, I have something kind of close to that. I'm going to go get checked. That's why I'm doing it. So here we go. Another one. And so these, we're going to be talking about a couple different types. And there is a type that is dangerous called Lentigo maligna. And Lentigo maligna, lentigos are freckles. That's a type of malignant melanoma that presents very similarly to a large lentigo simplex, which is large freckles. And this one pretty dark. You can see there's some light ones around. You see that almost black there. You can see the regression of pigment, that little white spot beside it. That's a guaranteed biopsy for most clinicians. But it's a good example of maybe something that was light brown for a long time and started turning black, they said, or darker, and that's why we biopsied it. Here is another one, and this is a great example of what I call the black sheep sign. There's all these signs, and they try to give you something you'll remember in your head in medicine, and there's all kinds of different signs. And the black sheep sign is one that we use in dermatology, and it's a striking sign. When you look into a field with 500 white sheep and there's one black sheep, how easy is that to find? It jumps out at you. You're like, whoa, look at that. Is that a wolf? What is that? You look closer, it's a black sheep. And that black sheep sign is a telling thing. As a clinician, it should make you say, whoa, what's going on there? And this is a perfect example of that black sheep sign. There's a ton of freckles around, all pretty much the same color. This one, almost black. If I recall this, it was almost black. It was pretty dark brown, but it was different from everything around it. And I was like, you know what? That needs to come off. And it was a melanoma. So that's a good catch. And now there is also something in children, and it's called a spitzoid melanoma. Kids get something called spitzoid atypia, and these spit cells are a type of cell that's in young skin in children. And this was a very young, I believe he was 8 years old. And this came up on his, I'm going to try to get this in good light. You can see there. So the dots around there, when you see these dots, that's my ink. I'm just inking just to mark where we're going to be biopsying and where I'm going to be numbing. However, you can see that's a black nodule. It's kind of thick. And the history on this was the mom was like, I don't like this. This is coming up quick. It came up very quick. I believe it got that big, 4 millimeters and 2 to 3 millimeters off the skin in less than 6 months, maybe 8 max. And they went somewhere, and it wasn't a derm office, and they had told them it's a hemangioma, or something called a pyogenic granuloma, which is an inflamed hemangioma. In saying that, they weren't completely off. That would be a differential sometimes, because pyogenic granulomas, when you have one of those red bumps I was talking about, an angioma or hemangioma, you can hit them sometimes, and they get really inflamed, and they can puff up and become very big and irritated. And sometimes that blood in there can actually kind of coagulate and turn darker. And it just kind of dries up, and it gets a very dark presentation. And that is definitely in the differential. However, just the history of this, and looking at real close at the base, you can see some light brown pigment right at the base, right, just barely. You can see it right there. There is a little bit of lighter brown pigment, like there was some type of mold that may have started there, and then this black just came out of the middle of it. Not the easiest biopsy to do. You know, sometimes certain children, you need to do, we play what I call the burrito game. And especially on younger kids. He was actually very tough, very strong, no problem numbing. He wanted it off. The mom, I think, had, I don't know if it scared him enough, but he just wanted it off of there. And he did well. He went to a specialist facial surgeon. They cut it off, and it was a melanoma. He didn't have anything in his lymph nodes, and it was a good outcome. That can go many different ways. But when I have younger kids, especially with facial lesions around the eye, they're very hard to have a needle right there and to numb them. And then once you numb them, because there was a little pinch, when you go to do the biopsy, they just assume that's going to hurt too, because they don't know. They're just children. So I will usually have parents, like, if they don't come in ready for it, and the child obviously isn't going to let me approach them, we play the burrito game. We have a big towel they bring in next time. They give them some Benadryl or something that makes them drowsy or tired or even asleep or falling asleep. And we wrap them in a towel, lay them on the bed, and then we kind of massage the head, and I kind of have the dad hold the head for me, because you don't want them going like this when you have a needle right there. And I secure the head as well, and I go very slow with a very small needle. They feel a little pinch, and it's almost instant that they're getting numb, and after that first pinch, they're usually good. It's a lot of breathing, talking gently, but that's how you do it. And you know, there are some kids you just can't do it. There are some bigger special needs people that are very strong and you just can't lull them into it, that need to be put on partial sedation like propofol to get their teeth done and to get simple biopsies like that. So that happens. Next. So you'll see this here. I know there's a shine. Let me see if I can close these, actually. That's better. Almost. Oh, I don't know. Oh, it's yours over there. Can you close that, babe? Do you mind closing that over there? Can you close that? Sorry, I didn't know you had. That's better. I was getting a shine here, but now I'm not getting as much ambient light. Let's try this. Here we go. Armpit right there for you guys. Okay, well, you know what? We're just going to go with it. It's obviously reflecting from everywhere. So this one, if I can get that light right. It's so bright. Bring it down a little bit here. I'm going to bring the light down on this. There we go. That might help. See if it helps a little bit. A little bit. So you can see here some melasma, some pigmentation on the face. And then that real dark spot in the middle is actually my ink overlapping on the two circles. And you look at this, and it doesn't look that bad. Those two spots are actually darker brown, obviously, but they're not black, but they do stand out from the surrounding, which is a black sheep sign. In particular, this lady had seen another office, a dermatology office, and they had told her, you know, she just has freckles, recommended laser, IPL, because she had this solar lentigos and some melasma. And she just wanted a biopsy. And I was like, you know, there's a chance it's that, but there's a chance it's lentigo maligna. It's dark enough for me, you know, I'll do it. It didn't take long. I did 2 biopsies, and it did come back as lentigo maligna, which is the type of melanoma. That's the one. That's the one. Just letting you know. Bless you. Mrs. Popzit is over here. She's working away. Here she is. Let's take a look. Hello, hello. There she is. We got a dual desk, like we're at the front of a plane flying. But she's got her earphones in, so she couldn't hear me, but she's looking at something that she was asking me about earlier. I was telling her that's it. So, yes, with this lady was so happy that I did the biopsy. She actually baked me cakes. 3 cakes over 6 months. She came back on follow-ups, and every time she just brought a cake. They were amazing. Different types of cakes. She was making these cakes. And yeah, I think she's beautiful too, Bella. Thank you. But yeah, so that was a lesson learned. This was way back when I first started practicing too. And it was a lesson learned that you know, history means a lot. She had said those spots were like the other color of the other things that were on her face. And then they started changing and got darker. History, so important. And I did the biopsies, and it was that. She had a big surgery, and she did great. And she was just so happy. And she was a patient of mine for years to come. You know, she was like, I'm going to you. Now, here is one right here. Trying to get the light just right. I know that doggone reflection. Now, that is not an obvious biopsy. It's not an obvious biopsy. This was a good catch. This is one I'm proud of. This is one where my clinical instinct was 55-45. It wasn't like, oh, I'm biopsying that today. I went in there, and what got me was right there, that little light spot. That little tiny spot I was like, that looks like regression. And then when you look to the side of it, right there, it's a little bit darker brown. Not black, very subtle. And I was just like, if you look as a whole, that mole to the where I circled, it just looks a little darker brown, and then to the side is lighter. That's color variegation. It's not dramatic, but I always say 2 or 3 of these things, of the A, B, C, D, E's of melanoma: asymmetry, border, color change, diameter bigger than 6 millimeters, and E is evolving. So the A, B, C, D, E's of melanoma, this had some color variegation. It had one side not looking like the other. It was bigger than 6 millimeters. It had some risk factors, not all of them, but it had enough for me that I was like, that it was the white spot that did it, really. That's what made me 55-45. I would have been 50-50 without that. And sometimes I'll be in a situation where the patient's like, I just really don't like this. And I'm like, well, let's err on the side of caution, and then we get surprised. This one was a surprise. I was thinking it could have been a moderate to severe atypia. It was lentigo maligna. It was a melanoma. And man, those are the dangerous ones. Caught it early. It wasn't real advanced. It wasn't deep in the skin, and they had a great outcome. So just an interesting case. Another lentigo maligna right here. If I turn that sideways, yeah, it's going to turn on me. Just going to try. Let me see if I get there. That's a little better. So here, you see this brown patch. Pretty universally brown, you know, just darker, not real black. But if you look on his other areas here, not so bad. Just some freckling. It does stand out. It's not like his normal lesions. In There is one follicle right there. There's a hair follicle there that can cause a little bit darker. There was a little bit darker brown spot. But was this a guarantee biopsy? No. The history mattered here. He told me, I was like, hey, how long has that been there? And he's like, oh, I've had that for years. And I'm like, has it changed? He's like, yeah, a little bit. In the last year, it got a little darker. Uniformly darker, pretty good oval border. But looking, when you back up and you look at their other moles and lesions and really kind of take them in as a whole, it doesn't match, and that is a black sheep sign. That is, you just get this little bing where you're like, I don't know. And instead of saying, I'm just the type of person that if I walked out of that room at night, I'd be sleeping in bed looking at the ceiling going, I probably should have biopsied that. I don't do that. I biopsy it. And I did, and it was Lentigo maligna. So a melanoma that looks very similar to a solar lentigo. So this is probably one of the most extravagant ones and probably one of the best stories. And you're going to see some dots here. That's not it. Those are my ink marks here and here. The lesion is there. Absolutely no pigment, no ulceration, not red, not painful. Pretty large, 9 millimeters to a centimeter. And this, we'll talk about scarring creams for sure, Jessica. So this case was a young woman in her 30s, and she had gone to 2 dermatologists. And she just wanted a she said, I just want a damn biopsy. So she said. And she was like, they told me it's a neurofibroma. And I was like, yeah, I probably agree with them. I think they're probably right. Neurofibromas will be they derive from nerve tissue. They're flesh colored. They're like almost like a tag a lot of times. No inflammation. They look very, very similar to that. And I did a full skin check for her. It was a busy day. There's always patients waiting, and you're trying to keep the day going. Unfortunately, it's just a side effect of medicine in America, especially. And I'll never forget this. I had my hand on the door, like literally, and she had just kind of told me, kind of like at the end. She had sandals on, and she was like, is there any way I can get just a damn biopsy on this? And I was like, well, it looks like a neurofibroma. How long has it been there? And I was like, what, 5-10 years, just getting bigger with my hand on the door? And she's like, no, it's been there 6 months or less. And I was like, 6, what? Like 6 months? That centimeter lesion grew? Did it bleed, hurt, or anything? She's like, no, it just came up kind of quick. And I was like, well, now I gotta do a biopsy. Thanks for telling me that. History is everything, man. History is everything. And so I biopsied it, amelanotic melanoma. Man, what a learning lesson, because there was nothing really in that other than her history, which you don't see when you're walking in. You don't see history, you ask about it. It looked fine. It didn't really have, other than big and bigger than 6 millimeters, nice round border to it, no ulceration, no pigment whatsoever. Man, scary. Those are scary lesions for any practitioner. The last thing you want is to walk out of that room and have a history that you saw somebody and you did a skin check and you even looked at it. And you didn't biopsy it and somebody else does and it's a melanoma. Oh, that's my worst nightmare. So biopsied it, melanoma. She lost a good half of her foot. They did a big, they saved her ankle, I believe. And she went on to become a melanoma speaker online and did a lot of great things. And as far as I know, she is still alive and well. I've gone on from companies where I found her. But it just, what a learning experience. And I share that picture is probably one of my most shared pictures when I'm training young people, whether it's a DO or an MD on a rotation, getting ready to become and finish up becoming a doctor, or they're in, new nurse practitioners or PAs. That picture is a wealth of knowledge in one shot. So that's a good one. Here's another one. And this is on the scalp. And just over, I think that's an inch. I don't even know if that's a centimeter. It's that paper. Hi, you want to say hi? Come here. You can come over here. You want to wave? Look at this one. Hi, baby girl. Look at that smile. Mwah. She was just feeling a little under the weather today, so she stayed home. In her nice little comfy jammies on a cold day. What a fun day.
I had a fever.
She had a little fever, but I think she's feeling better now. All right, baby girl. Mwah. Good to see you. So, those wide excisions absolutely can be brutal. I agree, but they're necessary. Getting those correct margins for clearance is a matter of life and death a lot of times. You can see here vascularity in there. I was thinking basal cell, actually. Obviously, I thought it was something bad. This one had a removal of something different. I think it was a basal cell. It was not a melanoma. And it was years before. And she had scar tissue on the whole top of her scalp apex. And then this shiny bump in the middle started coming up out of it. And then there's a lot of vascularity, which tells you some things. But taking a look at that, amelanotic melanoma, surprise. I wouldn't have guessed that. In good size growth, and she had a big removal, and it was very tough. She was over 75 or 80. And I think after a year, she didn't follow up anymore. And I think that may have cost her. The ones on the head sometimes get to these lymph nodes, and they're dangerous, very dangerous. Great lady. Man, just looking at that, it brings back. I remember talking with her, and it was tough because a lot of people thought it was scar tissue from her previous removal. Even I did when I first saw her. Thank you, Silver Zinc. When I first saw this, I was like, probably scar tissue. Let's keep a look at it. I didn't biopsy at the first visit. I actually had her back a couple weeks after. And I was like, this just isn't, it doesn't look right. It was kind of itching her and it was bothering her. She came in for something else, and I just saw it on the first visit. And I was like, yeah, it looks like scar tissue, but that center is looking a little off. And then she came back for a follow-up of what I originally saw her for. And I was like, man, it almost looks a little bigger. And that bump had just raised up a little more. So I was like, let's biopsy it. And then I called her when I got it. I was like, man, this is amelanotic melanoma. You need a surgery within a week. We're getting you in. Let's do this. And we got her, and she got good treatments, and I think it prolonged her life for quite a while, year and a half. And then, but gosh, good catch is the moral of that story. So this is an interesting case. This is a male, and that is a chest, and that is a scar right here. So this is one of only 3 I think I've ever seen in 15 years. I'm going to bring it in closer, just so you can see up close. Maybe I should bring the light up again. Huh? I made it to bring that light up. There we go. Made it to, you can kind of see that one better there. This is a Polypoid nevus. And a polypoid mole, you find them on the scalp a lot of times. They look like a little brain. So they almost look like a skin tag, but they're kind of lumpy like our brain looks. And they're just a type of mole. This was a polypoid melanoma. One of very few that I've seen in 15 years and seeing tens of thousands of moles. He did have a history of melanoma here on his chest. So that already piqued my, I was like, okay. And he, this is close. He had these seborrheic keratosis that were beside. And he told me this mole came up quick in 6 months or less. And I was like, that's a pretty good size to grow in 6 months. And and so we biopsied it, and it was a melanoma, man. It was strange, like a little met from his original. I don't know. Polypoid nevus, not all that common. Polypoid melanoma, a little bit of speckling, trying to get it in a good light. Not real black, just kind of a pink growth with some brown spots in it. Did have some color variegation, but quite a case. He ended up needing a big removal. I think he did have a sentinel node, but it was just one spot there. And he did great. He got on treatment, went to the oncologist, but good catch. That was another one that he had a skin check within the last year, and they had said it's just a tag. I don't think it was a dermatologist that saw him. I think he was seen by a mid-level, a PA or a nurse practitioner. And they're like, oh yeah, that's just a skin tag. And when I first saw it, I was like, yeah, it's probably, a skin tag or a polypoid nevus. But then his history with the scar right there, and the fact that it grew that quick, that close to a previous melanoma, instant biopsy. That was a for sure biopsy. And then I was surprised, though, that it was a polypoid melanoma. Kind of strange. So here we go. Next, acral lentiginous melanoma. These are nail beds. So there is something that happens on the nails, longitudinal melanonychia, which is a mole that can be up at the top here, and it will grow pigment down the nail. Benign, longitudinal melanonychia is a longitudinal growth of melanin that is benign. However, anybody having a mole there, the risk of acral melanoma, the nail bed is there. And when you look up acral melanoma and you look up longitudinal melanonychia, they do look quite different, but there is a transition phase that in there you start to see these little things. And one of the things you see here is pigment in the skin above the nail. So a lot of times longitudinal melanonychia, and it's pretty dark too. There's black in there, there's brown, there's color variegation. That's another telltale sign. But usually with longitudinal melanonychia, you'll just see pigment in the nail. When you start seeing it coming up in the skin up here, that is a sign it's a bad sign. It's a sign of atypia or melanoma. And so that was also, they usually lose a digit, the end of the finger or the finger. And that one, they went to a hand specialist surgeon. I don't think I saw them back. But what I do in a case like that, a lot of times, is do a core biopsy, a punch up in here to get that pigment. The other thing you can do, which I've also done, and it's not fun, is you do a digital block, you numb them, and then you take like a 3 millimeter punch biopsy, and you just drill, and you core, punch through the nail, you get the pigment on the nail bed, and you pull that out, and you send it. Yep, Bob Marley died us, right? Melanoma of his foot, I think of his nail or on the foot. But that's how you biopsy that. It's not an easy biopsy. A lot of people don't like doing them. They take time, but it's important because that's how you diagnose it. Very good case. So, last picture. Sad picture, really. And a lot of people say, what happens if you don't do anything? What does metastatic melanoma look like? And this is what metastatic melanoma looks like. And it's not pretty. That is all melanoma. And you can see here lymph nodes, lymph nodes, lymph nodes, lymph nodes, lymph nodes. He's full, probably in his lungs, probably all over. The sad thing about this is this was a cash patient of mine years ago, and he just had a little tiny spot on his cheek, little tiny mole. And it was dark, it was black, and I biopsied it, and it was melanoma. And he was a cash patient. He was a little stubborn. He had daughters that were, telling him, hey, you got to get this taken care of. And he lived, there's a lot of people in Southern California that live in Mexico and come back and forth and work back and forth. Some have dual citizenship. Some don't have citizenship. California, they can still get medical care. And what happened was, I think it was, I have very, very good staff that are very fluent Spanish speaking staff. And they understand melanoma, and I made sure with him and with his daughters, and we put it into the daughters, that he needs a big surgery, and it's important, and it's life or death. And we talked for quite a long time, and he wanted to get back down to his family, and he said he would come back. And he was leaving that week, and his daughters are the ones that came in because it was a dark spot. He had worked outside a lot of years, got a lot of sun, and his daughters are the ones that pulled him in. And they said he never goes to the doctor, which is very common in the Latin community, and in several communities, but in particular Latin community, can sometimes be doctor averse. They don't want to go in. A lot of different reasons for that, but it happens. And we spoke with him. He was in my office, and we're like, you got to come back for this surgery. And he didn't. He went back down south. The dark spot was gone, even though we had told him, this is melanoma. It can metastasize. You need another surgery that clears that lesion and gets the lymph nodes. And he just went away. And he didn't come back, and tried to call his daughters, and they were like, yes, he says he's going to come in. He says he's going to come in. Kept calling. And, you can only do so much as a clinician. It's very frustrating and sad. And he came back a year later, about 13 months later, and he was like, what's going on? And I was like, oh, the second he walked in, I knew exactly what it was. And you can see I got to prove that. So I do several here. I think I did 2 or 3 biopsies to make sure that all of those were malignant melanoma, and they were. And so in a case like that, it's a stat referral. It's a stat referral to the tertiary care, the schools. The schools where they're doing, in particular, I think it was Loma Linda University out here that was one of the closest. It was doing clinical trials on new medications for metastatic melanoma. Some of the ones that have mutations. And actually, they can actually have great results, even at that bad. There's about 55% of these melanomas have a type of BRAF mutation, or these types of mutations that the new medications actually, it regresses it quickly, and can even buy even a patient like that 5 to 7 years. 5 to 7 years on average. And I've had a couple patients at that point that got a lot more time, including the guy that I did the removal on his back that is in my video stream. We thought it was a cyst. I get in there, it was black as coal. He came back with Mets just like this, got on the medications, and it regressed. And his insurance changed. He moved. He needed to be seen regularly. And, I would have seen him. I did see him a couple times, just had him come in. But he ended up going to another place just because that was in his insurance. The place I was at, the insurance, it wasn't accepted at that place, and he needed a lot of visits, and he didn't want to pay out of pocket, and I didn't own the place, so I only had so much I could do. But he did great. He lived years and years, and as far as I know, he's still alive. This man didn't follow up, so he did go. I know he went. I talked to his daughters. I don't believe, this was years ago, that he lived over a year. But very sad, very preventable. Latin community, good question. I asked the question. I asked the question to my medical assistants, who are like family to me. They're so good, and they understand it's their culture. That's where they're from. And they tell me there's a lot of reasons. Sometimes it's a distrust of the medical professions. Sometimes it's a macho thing that nothing's going to take them. Sometimes it's fear that they don't want to come in. It's not one thing, it's multiple things. And I don't think, I think that's with anybody, all those things I said. However, I say that because my medical assistants have told me time and time again, this is something I see with my uncles, and something I see, in their family, that they don't want to go. And in particular with diabetes, blood pressure, eating a high carb diet, and not staying up on it, and having the side effects of diabetes and horrible neuropathies, foot ulcers, eye issues with retinal, arteries, all of that. So, and that was the last picture. I wanted to show the end, what metastatic melanoma looks like, and I really wanted to I wanted to do this since I've done this channel. I'm glad I had some time today. I actually I'm here. There's a contractor working at the house, and I took the day off. And to basically, I was like, I want to do this live because Melanoma Awareness Month is coming up also. The other pearls that I'm going to leave you with, and then we'll answer a couple questions. Can't believe it's 50 minutes already. It goes so fast. Areas of significance. So obviously, if somebody's got a spot on their hand and is getting even remotely darker, they're going to come in. It's the areas they can't see, which is why I check the backs of a lot of people, especially, the single older males, but a lot of people, I check their backs. But of importance are the scalp. The scalp, especially on women if they have parts, and on men with hair like me or thinning hair, that don't wear hats a lot. That's not something that you see often. And so in the scalp, I take my the forceps, the cotton tip applicators, and they have the wood sticks. You can kind of pull the hair and do a great scalp exam in less than 120 seconds, and go through and look for moles up there because they won't see them changing. When they do start to notice them, they're usually bleeding, ulcerated, or grow, and they're already like bad. So it's good to check there. Hairdressers are pretty good. I have a lot of people come in and I find melanomas that were found by hairdressers. Eyes, especially light eyes, especially people who are on boats or around snow a lot. Reflective light, if they're not wearing eye protection. Retinal melanomas happen. Not super common, but that UV light, you can get pigment on your retina, and you're not seeing that, oddly enough, even though it's in your eye. If you're not getting a slit lamp exam by an ophthalmologist, you are not seeing that. And that is one that will advance. I always recommend, even if you don't have eye issues, it's good to just get a baseline at some point in your 20s or 30s. Get an eye exam. They'll see if you have some weird pigment or anything on the retina. The other thing is bottom of the feet, in between the toes. Get down there. Get gloves on. Get in their feet, man, and get in the toes. It is recommended to do, that's a place where you'll catch some. They sometimes see those, but that's a place that they advance. They don't see it till it's getting bad. The last place is the anus and the genitalia. A proper skin exam, you should be checking that. I sometimes do. Not everybody's comfortable with it, and I tell people all the time, listen, I don't have to do a genital exam. If you want me to, we will. I'll tell you what to look for. If you know there's something there, bring it to my attention and we'll check there. It's to each his own. Not everybody likes those exams, but I tell people all the time, and I have caught melanomas this way. I tell guys, lift up the scrotum. Girls, look in the labia. Get a mirror. Get in there. Not every day, but every couple months, every 6 months, look in that area. You can have moles there. They're not going to get sun most of the time, although if you're doing tanning beds, they do. Those are the ones that change and nobody sees it, and they just don't see it. And then all of a sudden you got an ulcerated, bleeding thing, and then you have another spot popping up here. You're already getting metastasis. And I don't have pictures. I do have one picture actually, but I'm not going to show it because it'll get this particular video. In the genitalia, my first year and a half practicing, a month apart, strangely enough, I had a 20-year-old female with her mom. It was getting a skin check, and a 21-year-old female by herself. And I always have medical assistants with me, but I do a skin check. They're light. Both of them were light skin and light eyes, and history of tanning in their teenage years. History of atypical moles in the family, but nothing really for them at that point. They were kind of getting their first skin check. Do the skin check, some freckles, nothing really bad. And then I tell them, I'm not going to do a genital check, but I recommend you check that area. And both of them, I just saw their eyes light up. And I was like, if you have a dark spot there, if it's black, we should take a look at it. And they're like, I was kind of getting ready to leave. And they're like, yeah, I actually do. And I was like, all right, let's get you a gown. We'll get you comfortable. Your mom can stay in here. You know, my medical assistant is in here. And I look, and it's a black dot on the labia majora, on the inside of the outer lip. And it's small, 2-3 millimeters. And I biopsied it, and it was melanoma in situ. Great catch, just in time. And you know, a decent surgery, but able to hide the scar. I sent him to a specialist. I didn't do that surgery. You know, they're young, you know, a plastic surgeon along with like a urologist, usually a surgical specialist of the area, hid the scar great and got it out. Both girls, melanoma in situ. The other girl said the same. Oh gosh, I was shaving the other day. I see a spot. And I was like, okay, yeah, we got to biopsy that. We take a look. It's black. Melanoma in situ on her too. A month apart, strangely enough. And it was, you know, those you save those people's lives by just simply saying that. So if you're a clinician and you're hearing this, you might not stay 55 minutes into the video. I know I'm a little bit of a blowhard. I talk a lot. I'm getting the wrap up sign. They pull you off stage, you know, with the old. It's just I've pretty much been talking nonstop 55 minutes too. It's pretty easy. So you gonna take that over there. So. But life-saving, you know, if even one person sees this and they go in and they get that biopsied, awesome. That's what it's all about. So, yeah, check yourself. I always tell people, I see the picture, you see the movie, you know, and when you see the movie and you see the change and how it's going, you know way more, and you need that education as a provider. You got to ask the right questions to get that. So, very important. And yeah, so that pretty much is the end of my melanoma presentation. I think my battery even died on my mouse. I talked that long. It did. That's crazy. So let me come up here. So I want to look. I think there was some questions, and I definitely got 5 minutes of questions here. I really appreciate you guys all being here. I know on this channel, the people that are here 55 minutes in are the ones who really care and really want to learn, and I think that's awesome. Yeah, eczema on the scalp for sure. Perianal fistulas, man, I see them. Yeah, they're tough. A lot of times people have a history of constipation, bearing down. You get these connections from just inside the rectum to the skin around the anus, and you'll get chronic abscesses. I just had a patient 2 weeks ago with that. So very common, you know, a GI surgeon can take care of it, and it's important. But yeah, so yeah, my 6 months, ask about the genitals. You know, I have people that come, listen, I'm there to check, and I have people that come in like, let's go. I need to be checked. I am not shy. And then there are people who are shy that you really want to respect their comfort. I also have lots of different religions, in particular Muslim, covered up. The husband will be there. You got to respect that. And you know, you also want to, you know, help people, but it's very, very interesting, and I think a blessing for me to be in an area which is such a melting pot. It's such a melting pot of people and religions in the area I live that I get to see it all, and it's great. And it kind of trains you to be very respectful and to step slowly and have that conversation and ask the right questions of what they're comfortable with, and then tell them what to look for. If they'll see it and they can bring it up to you. And that's the best way I've found is to do it, and they'll know usually. And if they don't, they'll go look, and if they find something, they'll come back with it. So basal squamous turning into a melanoma. I have not seen that, and there's a reason for that. Now, these are different cellular structures that are turning into cancer. So the basal cell layer of the skin turns into basal cell carcinoma. Squamous cell layer of the skin turns into squamous cell carcinoma. And melanocytes are where, usually where our moles are, turn into malignant melanoma. So I have seen, though, you will have a basal cell growing by a mole that could be turning into a melanoma. So you will definitely have a crossover of tissues sometimes, But a basal cell turning into a melanocyte, no, I haven't seen that. But I just have seen people with really bad sun damage and multiple things all in one area. The other thing that I've seen that I think is interesting, and I'm just trying to throw some pearls out here for those who care. Seborrheic keratosis, so benign growth, and instantly you see that as a clinician, benign. Um, I have had an SK grow over a mole on somebody, and SKs in and of themselves can be black and be different colors and be kind of strange. And this one had a dark spot in a very black spot on a regular kind of variegated a little bit seborrheic keratosis. And I was like, well, that's a benign lesion, but it's dark enough. Let's just be safe. And so I did a nice saucerization biopsy, and it was a melanoma in situ deriving from the mole that the SK had kind of grown over. And man, that was a learning experience. And there have been multiple times where I have just biopsied some black SKs and they came back benign. But I've done quite a few because of that one patient. And it's just better to have a small scar than end up with a melanoma and die, obviously. So closing, I would just err on the side of caution always. And you'll always be doing the right thing from a clinician standpoint. And very, very rarely I've seen it happen, not with me, but a patient saying, you caused a scar and this was benign. And it's like, you obviously can't look as a clinician. You have a better eye, but you can't be 100% sure on something that's atypical or not. You just go by these parameters that I've mentioned and you make your best judgment, and you do that and talk with the patient, telling them why. As long as they know that, they're usually not going to be mad. And some scars are not fun. I know there were some scar questions. Silicone patches and vitamin C, vitamin E, serums for scar revision. They just help kind of putting on things that help scars heal as best they can. And then silicone increases the moisture and warmth when a scar is healing. Those two things together are probably your best foot forward with a scar, especially when you get these big melanoma removals. I know everybody's looking at their nails. That's funny, Lauren. Yeah, but you're putting your best foot forward. You're going to heal without it, but you'll heal, like they say, 30 to 40% better and quicker with some of these serums and silicone. So I hope that's good. Do you recommend dermatologist or your family doctor for a scalp cyst? It's a good question, Christy. I have seen some primary cares and some internal medicine doctors that are just very, very proficient in skin surgeries. Very good. Is that the norm? I don't think so. I think they usually refer out to the specialist. The scalp, when they're small, can be fairly easy. However, you can hit a bleeder pretty easily, even on small ones. And it's not that they couldn't do it or they can't throw a stitch in. We have cautery pins or better ways to stop bleeding a lot of times. Those cautery machines are expensive, and if they're not doing a lot of those procedures, they're not going to have it in their office. And ready to eat some?
Almost 2 hours.
No, it's been 1 hour. It's not 2
it's
hours.
Not. It's
I did do another video. I forgot. That's right. So yeah, that was right. It's a half an hour. So they might get themselves into a situation where they can't stop a small artery. So yeah, that's you got to take that into account. We're just doing it every day, so I would go to the place that does it a lot, which I found that's why a lot of people come to me because they've seen, wow, you got 500 surgeries online. I've seen your closures. I know you do it hundreds of times. They end up wanting to come to me because they know that I've done it. But there's any derm office, they're doing a lot of those, so they're usually very proficient. So it's probably time. It's so great to see all of you and see these common names. I appreciate you popping by. I hope I answered a lot of questions. I love that these lives sit here and people can find their way to them. I'm going to link it to my other video that I just did on my main channel. One reason I do the lives is because they do put commercials on these, and that helps the channel grow, and it helps me, to be able to pay for the bills of having a YouTube channel and all those things. So I appreciate you coming here, and I appreciate that growing. It's kind of fun. It's like a Durham podcast. So you guys have a great, happy Friday, and we will talk again. I'm going to do more of these educational ones. I kind of was doing it for a while. I enjoy it when I have time, which is limited, but I'll get in there and do it. So Thanks for popping by. Let's talk again soon. We'll see you.